Hi everyone, and welcome to the latest in our series of video interviews. Today I'm joined by Professor Melendez-Torres. Now he works as Professor of Clinical and Social Epidemiology at the University of Exeter Medical School. He leads the Peninsula Technology Assessment Group, which is one of 9 research units in the UK that provides expert advice on the clinical and cost effectiveness of new drugs to NICE, the National Institute for Health and Care Excellence. He's also Deputy Director of the Exeter NIHR Policy Research Programme Evidence Reviews Facility, which is a bit of a mouthful, and the Programme Director for the brand new Masters in Public Health at Exeter Medical School. So welcome, Gio. Thanks so much for joining me.
Thanks for having me.
Now, I just wanted to start off, we hear so much about public health at the moment. It's in the news all the time. But what actually is it as a subject, and what differentiates it from other areas of medicine and health?
Public health is the health of the public, which sounds a bit obvious, doesn't it? Public health, I think, is often defined in terms of its component disciplines. But I think what really makes public health is a concern for the health of populations. And realizing that those populations are composed of communities, which are composed of families, which are composed of individuals who each have their own life story, who each have their own history of health as they go through life, who experience a lot of the same kinds of things that you and I experience every day, and many people who don't. So at its core, what is public health? Public health is about trying to understand and improve how it is that health comes to exist in populations, how it is that health problems come to exist in populations, but just as importantly, why it is that those health problems come to exist and what we can do about them.
So do you consider things like economics and policy and stuff like that, as well as just the health side of things?
So I think there are 2 things I'd say. I think the first is economics really that different from health? What do we know? We know consistently that poverty is a major risk factor for poor health. We know that living with food insecurity and housing insecurity is a major factor for poor health and well-being. So in that sense, all economic policy is in a sense health policy.
Okay.
It's one of those adages from the field of public health that all social policy, all public policy, all economic policy is really health policy, in the sense that all of these policies have really meaningful and direct impacts, and in many cases indirect impacts as well, on the health status of populations. So what does this mean? What this means is that I think we generally view it as being within our province, particularly the social epidemiologists and the environmental epidemiologists as well, to understand how it is that economic policy, economic status impacts health and well-being. That also extends, and I think this is really important, this also extends centrally to understanding the health impacts of inequality. Okay? Inequalities are not just the fact of health difference in populations. Inequalities, or more specifically, inequities, also relate to the ways in which those differences in health within populations are socially patterned. How they come to exist as a result of social discrimination, how they come to exist out of unequal access to opportunities and unequal access to healthcare, even in the context of national healthcare systems like the NHS. What do we know? We know that inequality is bad for health, not just for the people on the receiving end, so to speak, of those inequalities, but also at the population level. More unequal populations are also less healthy populations.
I mean, talking about inequality there, obviously infrastructure varies around the world, access to health services varies around the world. I mean, are there any kind of best practices? Is there anything that we can do to improve that inequality?
Sure, so nowhere is perfect. Everyone has their own combination of victories and challenges. For example, something that we have been seeing now is that there has been a real victory of local public health infrastructure in many low and middle income countries that are doing their best to address the coronavirus situation.
Yeah.
What we've seen is that local contact tracing, local pandemic preparedness, local epidemic readiness, local development of human resources for health, the kinds of community health workers who are often on the front lines doing that health, is a major victory that multiple low and middle income countries have seen in addressing coronavirus. Victories that, to be blunt, many high income countries have not been able to replicate.
Yeah.
What we've also seen is that a general focus, and this is thinking about beyond coronavirus, a general focus on upstream interventions, on addressing the conditions through which health come to exist, is absolutely central to having effective population action on health. What do I mean by that? Often when we think about public health, we think about the local, very behavioral things that we can be doing to improve our health, so-called lifestyle medicine. How can we optimize our lifestyles to make them as publicly healthy as possible?
Yeah.
Thinking about things like getting out to walk every day, eating 3 square meals, eating the appropriate number of fruits and vegetables a day, 5 a day, right? Those things are all really important. And I think it's important that people know that they need to do those things. And it's also important that people have the skills to do those things. However, when we focus on those things, we often forget that there are larger structural determinants at play. What do I mean by structural determinants? How can you get out to have daily exercise if you live in an unsafe community? How can you have access to those, how can you be eating those 5 a day of fruits and vegetables if you live in a context where access to that is very difficult? So the most effective things we can be doing to improve public health, when we improving the health of populations, is taking action upstream. Taking action to improve the conditions and contexts by which better health can be created. Working to reduce inequality. And something that I think the UK certainly has going for it is that it has a very strong, very powerful national health system. That has the potential, and it is in many ways now, but could be even more effectively used. That has really the potential to be an extremely important equalizer in terms of health status, making sure that everyone has fair and free access to healthcare. The more that we see national governments, the more that we see governments around the world try and innovate in terms of how we deliver healthcare at scale, at speed, with high quality, and with maximum equality, the more that I think we'll see population health status improve at a national and international level.
How do you use the information from things like the COVID pandemic at the moment when it comes to improving policy and making decisions in the future?
I think there's a lot of learning that can happen as a result of this. Several colleagues recently published a paper in the journal Critical Public Health that pointed out that one of the most surprising aspects of the response to this pandemic, certainly in the UK, has been an interface between science and policy that is in many ways remarkably conservative, that focuses on monodisciplinary insights. And when I mean monodisciplinary, I don't mean public health, which is an interdisciplinary field. I mean very specific things like environmental engineering, right, or clinical medicine, respiratory medicine, or the very specific aspects of economic policy. I think what is needed, and one of the things that I hope that we'll learn coming out of this pandemic, whenever we come out of it, is that in order to continue developing the most effective and efficient solutions, and in order to really maximize the value of the learning, we need to move beyond monodisciplinary insights to insights that are truly interdisciplinary. I'll give you an example. I was recently doing some work with colleagues to inform the national response to coronavirus. And that work focused on how can we optimize the co-production of guidance to support local families, communities, and businesses in responding. When I say co-production, what I mean is transmitting knowledge and generating learning that isn't top-down, that doesn't come from the people sitting in the offices and is announced to the people on the ground. But knowledge and learning and guidance that is locally relevant, locally meaningful, locally important, and that actually respects and understands local contexts, okay? Rural communities, for example, will have a very different time, space, and ability to respond to coronavirus than large urban centers.
Yeah.
So co-production is really important because that's one way that we can maximize the relevance. And I've been really fortunate to learn a lot about co-production from a really excellent public and patient involvement team in the medical school, who I just really think are an inspiration in terms of shaping how we understand co-production. When we think about co-production and when we think about why that's relevant in coronavirus, co-production is a thing that we do, but the reasons why it might be useful are meaningful in a range of different ways. From a public health perspective, or specifically from an epidemiological perspective, I believe co-production is important because it improves the effectiveness of whatever it is that we do. Colleagues of mine who are anthropologists, and particularly anthropologists of government who I was working with on this, noted co-production is important because it engenders a sense of fairness and equality, and a sense of buy-in. Colleagues of mine who are lawyers, who are experts in social justice, point out that co-production is important because it's a critical way in which the government fulfills its obligations and responsibilities to the citizens over which it exercises power. So the idea is that you have this one central function that we need to be doing to respond to the pandemic that is interesting and valuable and relevant from a range of perspectives. In order to really make sure that we're optimizing the learning that we're having from this pandemic, we need to be focusing on developing those kinds of interdisciplinary and multidisciplinary insights, because I believe that's the only way that we'll find ourselves not in the same position that we found ourselves when Corona first became a problem in the UK.
Yeah, I mean, I guess that goes back to what you were saying earlier with some countries working more locally, having people on the ground, so they may not have the same resources as other countries, but just the way they've worked, can you say, actually?
And one of the things that I think is interesting about that is that I think it really calls up something that's developing more prominence in the field of public health. So we generally have this model of learning that prioritizes North-South learning. So learning is generated in the global North, where all the money and the fancy research universities are, and then it's kind of sent to the global South, the low middle income countries, where they're expected to be grateful and to receive this knowledge and to delight in all of the knowledge that has been generated by the people of North. I think one thing that this pandemic has thrown into really stark relief is that we ignore the potential for South-North learning at our peril.
Yeah.
We ignore the learning from really strong, highly networked, locally relevant public health systems in the global South at our peril. Because if there's one thing that we know for a fact has worked, it has been really powerful, well-resourced, highly experienced local public health working to develop solutions that are locally relevant to where people are and where people live and how health occurs, to coin a phrase, how health occurs in those local contexts.
Brilliant. Now I just want to change the subject a little bit because you just have launched a new Masters in Public Health. So you're going to be training the next generation of public health experts at the Exeter Medical School. So what kind of things are people going to be studying? What kind of modules, what kind of topics?
So I think it's really important that we believe our own hype about interdisciplinarity, that we take our own commitments seriously in that regard. So we really believe that our new Master of Public Health, or MPH, is first in class, and certainly first in the world, in the sense that it takes a lot of what you would generally think as being the basic sciences of public health and turns them on their head.
Okay.
There's a reason why they're basic sciences, there's a reason they're important. You know, as an epidemiologist, I love epidemiology. But you can't study these things in isolation, you can't study them in silos. What we've done is that we've taken the traditional MPH and turned it on its head and asked ourselves, not what is the knowledge you need to be filled up with at the end of this program, but rather what are the sparks that we need to be igniting to support you in becoming a public health leader. The very first question we ask on day one of the MPH is, what does it mean to think like a public health expert?
Okay.
And we start from there. So the very first module on our program is called Structuring and Solving Public Health Problems, because that is the central focus, we believe, of an MPH, to support students in becoming experts in structuring and solving public health problems. So we take that as our departure point. On day one, we start thinking about how do biological and social health problems interact with each other. On day two, we start talking about, okay, how can we remix that by taking into account the value of complexity? And on day three and day four, we start thinking about what are the kinds of leadership abilities and competencies, the kinds of strategic expertise you will need to generate relevant and effective solutions to public health problems. So we take that as our starting point, and then we really are kind of excited. We really are excited to walk on this journey with students as they develop and learn and become expert leaders and decision makers in public health.
Brilliant. Now, this is going to seem really obvious right now, considering we are still in the middle of a pandemic. But why are having public health experts, why is that so important?
Because I think, as I said at the beginning of our conversation, all policy is health policy. Health needs to be in all policies. Health needs to be everywhere, because whatever action we take, whether it's about education, whether it's about social care, whether it's about economic policy, whether it's policy relating to trade and foreign investment, every single policy decision that is made at any level of the world has important implications for health.
Yep.
Public health belongs everywhere because I firmly believe that public health is the work of our governments. Public health is the work of our communities. And so as a result of that, we need to have health in all policies and health in all places. And it is my sincerest hope that we're entering into a new era where if there's one thing we learned about this pandemic, it's that all policies have an impact on health, but also health has an impact on all policies.
Definitely, definitely. Well, thank you so much for joining me and for answering
My
my quite silly questions at some point there. It's been really interesting for me to listen to hear more, and I think, I hope everyone else has joined as well.
Thanks for having me.